Primary congenital glaucoma, PCG. So it is rare with an incidence of 1 in 10,000 in many populations. Boys are more commonly affected than girls. In most surveys, involvement is more often bilateral but frequently asymmetrical. It can be classified into many types like true congenital glaucoma, which occurs in 40%, in which IOP is elevated during intrauterine life. So this is true congenital glaucoma, intrauterine life. Infantile glaucoma, 55% of cases are which manifest prior to age 3. So infantile glaucoma. Juvenile glaucoma is the least common, in which IOP rises between 3 and 16 years of age. So all threes are combinedly called primary congenital glaucoma. Primary congenital glaucoma is by definition not associated with other major ocular abnormalities. It is thought to be caused by impaired aqueous outflow due to maldevelopment of the anterior chamber angle, trabeculodystogenesis. It is usually sporadic, but approximately 10% are inherited. So, in autosomal recessive fashion, variable penetrance, several genes have implicated, prominently CYP1B1. Prognosis is dependent on severity and age at onset. So age at onset or age at diagnosis. Secondary infantile glaucoma can be caused by a range of conditions including tumors such as retinoblastoma, persistent fetal vasculature, persistent hyperplastic, primary vitreous also known as, and uveitis. Diagnosis. Presentation usually occurs when an abnormality such as corneal haze, large or asymmetric eyes, watering, photophobia, blepharospasm is noticed by parents or health professionals. Watering, photophobia and blepharospasm. Corneal haze is due to diffuse edema secondary to raised IOP or localized edema due to bricks in Descemet's membrane. Ophthalmos is a large eye as a result of stretching due to elevated IOP prior to the age of 3 years. The thin sclera often appears blue due to increased visualization of the underlying uvea. Complications include myopia and lens subluxations. So the complications include myopia and lens subluxation. The Hofstra are curvilinear healed breaks in the Descemet membranes. Curvilinear healed breaks in the Descemet membranes. Corneal scarring and vascularization. Optic disc cupping in infants may regress once IOP is normalized. Most normal infants exhibit no apparent cup. Evaluation under general anesthesia is generally required. Intravenous ketamine lowers IOP less than other agents. The IOP measurement should be performed first, optimally with more than one method. For example, Perkins, Tonopin, eye care. It is preferable where possible for this to be measured in a conscious or sedated child. 10 to 12 mm of mercury is normal. 10 to 12 is normal. Anterior chamber examination with an operating microscope and or portable slit lamp. Optic disc examination, asymmetry or a cup disc ratio of more than 0.3 is suspicious. corneal diameter measurement of more than 12 mm prior to the age of 1 year is highly suspicious. Gonioscopy using a direct corneal lens may be normal or reveal trabeculodysgenesis, vaguely characterized by anteriorly located iris insertion and a hypoplastic appearing peripheral iris. The old concept of discrete Burton membrane has not been definitively confirmed, and refraction should be performed. Surgery is always required and is successful in 80 to 90%. Medication may be used as temporary or supplementary therapy. Caution is required with selection of medication in young children as most are relatively contraindicated. Goniotomy under direct gonioscopic visualization, and incision is made at the midpoint of the trabecular meshwork. Trabeculectomy may be necessary if corneal clouding prevents an adequate view of the angle and is also an option when the repeated goniotomy has failed. Partial thickness scleral flap is created. And a Harm's trabeculotome is inserted into the Schlemm canal and rotated into the anterior chamber. So this is trabeculectomy. Trabeculotomy. This is not trabeculectomy, this is trabeculotomy. A modification of trabeculotomy is used in some centers. An illuminated canaloplasty device is threaded into the Schlemm canal followed by a 6-0 Prolene suture, which is then pulled into the anterior chamber, thus opening 360 degrees of the trabecular meshwork. The post-operative IOP using this technique is approximately 5 mm of mercury lower at 2 years than that obtained with traditional approach. Other procedures when angle surgery fails include trabeculectomy, tube shunt implantation, ciliary body ablative procedures. Monitoring of IOP, corneal diameter, other parameters is required in the long term. Myopia and refractive error should be managed aggressively. Differential diagnoses of the cloudy cornea are barotrauma, rubella, keratitis, also known as congenital rubella. Congenital rubella is also associated with congenital glaucoma. Metabolic disorders such as mucopolysaccharidosis and mucolipidosis, congenital hereditary endothelial dystrophy, and sclerocornea. Large cornea differentials are megalocornea and high myopia. The epipora differentials are delayed failed canalization of the nasolacrimal duct, lacrimation secondary to ocular irritation, conjunctivitis, aberrant eyelashes, and entropia.